Great. Hello, everybody. Welcome to this month's Value-Based Healthcast. My name's David Hanna, and I'm normally joined by Nick Wilkinson, but as you can see today, clearly this is not Nick. I'm being joined by Dee Lowry today, who's Head of Value-Based Healthcare for Cumtaff Organic Health Board. So for those of you who may be joining us for the first time, our Value-Based Healthcast is something that we do in conjunction with Sally Lewis and the Wales Value and Health Centre. And it's our monthly webinar meeting where we invite guests who are doing value-related projects from around Wales to come and share some of the work they're doing, some of the successes, the failures, but really with the purpose of learning what's going on in Wales and how to get things done in the area of value-based healthcare. So we've got what we hope will be a fantastic session today. We've been joined by two guests, and I'm going to hand over to Dee to introduce them and tell you what it's all about today.
Yeah, cheers, Dave. Nice to see everyone back again. So definitely not Nick, but standing in for this next one, which is a really exciting one, talking about the value-based healthcare allocation. And our two guests today, our first is Keely Flowers. She is Finance Programme Lead at the for Value-Based Healthcare in the financial plan delivery as part of the NHS Wales Executive. And we're also joined by one of my colleagues in CTM, Dr. Di Samuel. He's a consultant hepatologist. He's got a whole range of other things he does as well. So Foundation Programme Director at RTILG, Clinical Lead for Gastroenterology, RGH and IQWILS, and also at Royal Glamorgan Hospital. So when we think about value-based healthcare, there's been a lot of talk about how our projects are funded. Does everything always mean that we need more staff? How do we fund that? But also, how do we get to fund areas of innovation and improvement? So our two speakers today, Keely's going to talk about the national allocation that is managed across Welsh Government and how that's split. This is pretty rare internationally for value-based healthcare. So, you know, having that top-down support to enable this work to take place is very exciting. So Keely's going to provide some overview on the work that she's been doing, looking at where the allocation's gone and where it's come from. And Di is going to cover the project that he's been leading on a 24/7 alcohol care team at Cumtaff Morgannwg. So Keely and Di, thank you ever so much for joining us today. And Keely, I'm going to hand over to you.
Thank you, Dee. Hi, everyone. Just share my slides. So are my slides coming through, Dee and David? Yeah, all good. Thank you. So hello, everyone. As Dee mentioned, today I'm going to be talking about the Value-Based Healthcare Allocation Fund and some of the impact that it's had across Wales. So firstly, just a quick disclaimer from me. So I'm usually a viewer of this podcast. I do thoroughly enjoy watching it once a month on a Friday afternoon, and I've really enjoyed some of the topics that have been covered so far. I think, you know, I would consider some of the previous hosts to be experts in value. So now I'm slightly newer to value than some of the previous experts, but I've got a bit of story of my history of value-based healthcare and how I've kind of come about into coming into this role. So I joined an Iron Bevan Health Board as a young and fresh 18-year-old about 7 or 8 years ago now. And I was lucky enough in my first or second year to spend a bit of time with Dr. Sally Lewis and Adele Carhill in their newly formed value-based healthcare team. So yeah, I was really lucky enough to get a good grounding of value in that time. It gave me just a really good kind of overview and understanding of the subject. And it was actually one of my first placements as a trainee, kind of working closely with the service, and where I actually saw my first procedure in a theatre. So it's really stuck with me for the last couple of years. And you know, over time then I moved on, qualified as an accountant and worked in finance business partnering teams. But value has definitely always kind of stuck with me and stayed with me through my career. So I'm really lucky now actually to be in a role focusing solely on value, but I'm fairly new to it, so I've only been in the role kind of coming up to 5 months now. But yeah, really lucky to be in a role that's solely focusing on value now. Just to say, you know, as always, this presentation is quite factually based, but any kind of views I talk about will be my own personal views and don't reflect the kind of views of the NHS exec. And just to give a bit of context as well, I think, value is more important now than ever. I think it's important that people know that it's not the solution to the current deficit in NHS Wales, but if we adopt and scale value-based healthcare now, we will move toward long-term sustainability. And for me, I think it is the only answer to long-term sustainability in the NHS to support recovery and service transformation going forward. So that was just my quick disclaimer. So what is the Allocation Fund? So back in 2022, so last year, Welsh Government announced 20 million funding for value-based recovery. As Dee mentioned, internationally, that's probably quite sought after. So I think we were really lucky in that case. In the kind of disclosure of the allocation, Welsh Government stipulated that this would be a collaborative approach between the Welsh Value and Health Centre, my team in the Financial Planning and Delivery Unit, previously the Finance Delivery Unit, the FDU as most people know it, to provide support to local health boards to deliver the expected benefits of the funding. So what were the expected benefits? So the fund was effectively split into two parts. So there was a 15 million section of the funding, which is now 14 million in this financial year, and a 5 million section. So the 15 million was allocated to health boards on a population basis. So it was allocated across the 7 health boards to mainly focus on the delivery of high value interventions and ensure improved outcomes for patients. The 5 million then was held back centrally by government to support development and implementation of value across Wales. So this was offered out to health boards, trusts and clinical networks to effectively bid for part of the 5 million. It was really successful. So I think we received about 60 bids, which was just incredible. And again, really great for Wales. Part of a kind of specialist panel made up of Welsh Value and Health Centre and the Financial Planning and Delivery Directorate kind of narrowed that down to 16 successful bids, which I'll talk about a little bit more in the next slide. Just on the collaboration part then, so as part of the evaluation and monitoring of the allocation fund, myself and colleagues across my team and the Welsh Value and Health Centre have developed a kind of evaluation template. So this has really been kind of key in helping us develop an evidence base to just really demonstrate this funding was an enabler for change. So I'll talk about some of the impact that it's had across Wales already, which is, we've only had the funding for just short of a year now. So I'll talk about the 15/14 million first. So this has spanned across 25 service areas across the 7 health boards. This is absolutely brilliant. I think it's just really demonstrated a huge kind of service change impact and improvement in outcomes across the health boards. So some kind of areas in particular, I won't talk about all these examples, and there are plenty more examples than this that I could go through, but just to touch on a few. So in diabetes, and Iron Bevan have been looking at inpatient education. Cardiff and Vale have looked at community diabetes hub. In orthopedics then, so Betsy have been looking at hands, hips and knees in terms of service redesign and pathway and outcomes. And then finally, PROMs and infrastructure. So if anyone's not aware of what PROMs are, so the basically question is to measure patients' view of their health, help improve outcomes and what's important to them. So with PROMs, we've been able to implement that in a lot more areas now, and some of those areas include respiratory, heart failure and cancer services. Infrastructure then, so a specific example on that one. So Powys Health Board used the funding to enable and kind of establish the value-based healthcare team, which was absolutely brilliant for Powys. In terms of the 5 million then, so I've got a couple of examples on there. So wound management, again at ABHB, increased the use for specialists dressing in gynae and colorectal for high-risk patients to improve their clinical outcomes. Alcohol liaison, so I'll leave that to Di to talk about next. The Value Intelligence Centre, so this was basically Velindre working to enable a data-driven and evidence approach to implement the value-based healthcare in Velindre. And finally, atrial fibrillation. So there was a collaborative approach by Howells Ark, Cwmtaf and Swansea Bay to look at service redesign for better screening, diagnosis, education and preventing stroke-related AF. So I just wanted to touch on something we've been looking at as a whole pathway approach to value-based healthcare. So this looks at all kind of steps of the pathway for a patient, right from prevention to diagnosis, optimising the intervention, supportive treatment, and finally end-of-life care. So I just wanted to use a couple of examples of how we can demonstrate that this funding is spanned across the whole pathway of the patient, not just kind of looking at keeping them out of hospital. So first of all, preoperative anaemia. So this was to implement the pre-op anemia pathway in Wales. So this was looking at screening for patients that undergo a major surgery for anemia to treat with iron and reduce the risk of a transfusion. So currently anemia affects 30 to 60% of patients undergo a major elective surgery. So this is basically to look to create a robust screening treatment and process, which will be key to better post-surgery outcomes. So optimizing the intervention then, so we're looking at a self-management app for diabetes in pregnant women. So CUMTAF have established the GDM app for pregnant women with gestational diabetes. This is looking at personalised care to kind of monitor their blood sugar and symptoms and just kind of improve their journey overall. Again, optimise intervention. So in heart failure in Swansea Bay, they've implemented some annual MOT style reviews for heart failure patients. So this is looking at early diagnosis for any deterioration and just trying to keep patients as well as they possibly can be. End of life supportive care. So this is a great piece of work done in Cardiff and Vale. So this is looking at palliative care in patients with heart failure, just to really suit the needs and wishes of the patient. This has been absolutely brilliantly well received, and I think has really had a mark on Wales. So other chronic conditions are now looking at this, and other health boards too. So that's a really great example there. So just to wrap up then, I'm just going to finish on 3 important points that I think were incredibly important in the allocation fund, but and my opinion in value-based healthcare as a whole. So first of all, motivation. I think people watching this podcast will clearly have an interest in value-based healthcare. I just urge you to keep that interest and momentum. Whether you're a clinician working in finance, I think just continue to be curious. I think all ideas are worth kind of talking through. So yeah, please be resilient and keep that interest in value. Data. So I think early reflections from some of the evaluating of the allocation fund. I think we need to be a little bit better at our benefits realisation. I think for me, we need to be really sharp on our data in finance, PROM, so patient reported outcomes, and clinical outcomes. If we look to potentially ask for more funding or just demonstrate the real impact that this has had, I think we need to be really kind of emphasising on data and getting just a good source of data there. Collaboration finally. So I think multi-agency engagement and value is key. I think we achieve more when we work together. Everyone wants the best for the NHS ultimately, and I do think sometimes change can be difficult, but we need to support each other to embed and achieve impact and value going forward. And that's it from me. So we're happy to take any questions, and thank you everyone.
Lovely, thank you, Keely. I hope everyone found that really interesting. It's really good to hear some of the examples of where the funding has gone, and I think there'll be lots of people online, including us in the room here, that will be looking forward to hearing some of the outcomes of all the other projects. And I think the idea there of the collaboration really helps when we think about the scale up, because we've all got the same issues. We are trying to solve some of the same problems. And what the allocation actually puts on us as well is almost like a duty to share. So it breaks down the competition, or it wasn't developed in my backyard, to say actually in getting the allocation, we need to share, test it once, evidence it, and if it's working, how do we roll that out much quicker? So I can speak from personal experience, and I know Di will be coming on in a moment, what it means from a clinical point of view, but from a managerial point of view, in trying to drive value-based healthcare forward, we were trying to do it with no funding beforehand, and it was moving. It's moved significantly, but it was on the back of the willing, and we had lots of sporadic projects. By actually having some funding and being able to really drive this forward, it really helps us to do that whole systems approach and to have the clinical time, the data and the evidence to really understand those golden ticks about what we are spending and is it valuable to everybody, to finance, so when we're doing our procurement for the clinician and for the patient, foremost. So thank you very much. We are going to, if we move on to Di next, and then we'll have a big question section. So if I can just say to anybody, if you've got any questions, pop them in the chat for us, and then we'll bring them into the question section for you. So Di, over to you.
Thank you, Dee. So yeah, thank you for giving me the opportunity this afternoon to give an overview of how far we've come with regards alcohol care teams in CTM over the past 14 months, and I hope that the next few slides will inspire others to take that difficult journey. And as Dee says, too often we do this on goodwill, but now that we have some finance behind us, hopefully we can make a real big difference to patients' lives and outcomes. So why alcohol? It's often seen as something that people make a choice to use or misuse, but there's far more to it than that. And certainly I think in the pandemic, we saw that alcohol consumption increased significantly and has brought to the forefront and to the surface lots of patients who perhaps were already drinking heavily beforehand and have just gone up that extra notch. But it then causes things like cirrhosis and cancer, but also lots of other issues within the healthcare system and society, which if we can prevent, actually saves a lot of money for society as a whole. And we see a lot of these frequent attenders within the A&E departments, and their lives are quite chaotic, quite complex and quite tragic, and alcohol is their way of coping, but it drives their ongoing behaviours and ultimately causes them harm. And we know from other work in other countries and other centres that early engagement reduces long-term harm, costs, and actually could put me out of a job in a few years' time if we prevent anyone getting liver disease. So this is just a snapshot about alcohol in Wales, really. So in 2018-19, so remember this is pre-pandemic, the average annual consumption of all drinkers was 530 units. But we had a massive range there for moderate drinkers consuming 221 units a year, to those at the top end drinking almost 4,000 units. Now, that's a lot of pints, trust me. That's about 2,000 pints a year. So you can just imagine how many they're drinking per day. But the worry is that at the top end, you've got 2% who are the harmful drinkers consuming 23% of the overall alcohol. And those are the ones that sadly we see coming through our A&E departments regularly, sadly then end up in my clinics and very sadly often dying at a very young age. And again, we have a problem within our youth as well, in that over 50% of boys and girls in Wales have said that they've drunk underage at least twice and have been drunk. So we need to address this from an early age to prevent our harmful drinking becoming normal within our school age population as well. And as I say, COVID has caused a lot of harm. We've seen the COVID-related death being the highlight on the news, but certainly in my clinics, I've seen lots of people who had no issues before COVID coming forward now with harmful drinking habits because of stress and anxiety, being lonely, being isolated, being bored, and misinformation as well, thinking that it is okay to drink every day. So we're going to see the legacy of COVID, I think, for many years to come, and we're only now seeing the start of that tsunami of alcohol-related harm coming towards us. And again, people think that alcohol is just something that alcoholics drink and it only affects the liver, but it's not just that. It's all of these other things that affect every single one of our departments. And we've heard already about heart disease and cardiology having some of the money this year. Alcohol is a significant harmful toxic effect to the heart, can cause atrial fibrillation, cardiomyopathy and heart failure. So stopping people drinking excessively won't just help our services, it'll help every one of these services, all of which are already overwhelmed. So what have we got at the moment? Well, we're essentially a liaison or a firefighting service, as I like to call it, at the present time. In Prince Charles and Royal Glam, we've got a single band 6 sitting under the Mental Health Directorate. Their working patterns are the working day, so Monday to Friday, and most people with alcohol-related issues, be it ongoing chronic issues or acute, coming out of hours. So we're missing those people and the opportunity to engage. We receive most referrals from the ED, sometimes from the wards. It's very ad hoc, and it's just really a signposting exercise to help people take responsibility for themselves to get help. And that's not always easy when they've got complex psychological and social issues ongoing. And we don't really know who we're missing because we're only there 5 days a week for 8 hours. We're probably missing a hell of a lot more, probably the more harmful drinkers who really need our help. In Princess of Wales, it's slightly different. They have a substance misuse team. And again, they provide some very brief intervention, more signposting, and again, similar challenges for picking cases out of hours. So what does an alcohol care team look like and what do we aspire to? So we want a 7-day service capturing not just the high attendance period of Friday, Saturday, Sunday and night times. We want to be running it throughout the working day and into the evening during the weeks as well. We want to be able to provide robust cover. With my other hat on, without money, I've been trying to fight for many months to get a second liver nurse in Prince Charles funded permanently. And we've been told no quite a lot, but my argument always is back to them. You can never run a high quality service with N of 1, because if N of 1 disappears, then there is no service at all. So providing that cross cover, which will be crucial. We want to try and do a lot more in-reach. So rather than firefighting, let's proactively go and look for these people. Let's go to pre-assessment clinics for operations. Let's help our head and neck colleagues. Let's go to care the elderly wards and clinics where older people have fallen over because of alcohol. So we want to try and stop people coming to harm in the first place. One of the biggest achievements that as a team we've done is we've engaged with maternity services. I'm very passionate to prevent the next generation being harmed by alcohol, and it's a condition called fecal alcohol syndrome, which can be caused by any amount of drinking in pregnancy. And our maternity services have opened with both hands their services to us. I'm going to be running a dry mester campaign and looking to screen every individual going through maternity services for alcohol misuse, as well as their partners, and offer them support throughout pregnancy and beyond. And then we want to take this to the community. There's no point waiting for people to come to us in the hospital. We want to go out into the communities, out into the GP clusters, and pick these people up before they ever hit an A&E department or one of my clinics. And the final thing then is the top end harmful drinkers are often at a loss. They're desperate. They have no support. So what we are aiming to do is those high end people, we will be chasing them like a little corgi. We will have our healthcare assistants going to see them every day, waking them up, telling them, come on, let's have a shower, let's go shopping, let's take you to your appointments. Because if we get them engaged, they'll feel valued. And if patients feel valued, they'll have a better outcome. The business case, so we're going to have a band 7 to oversee the service, manage the more complex patients, with 2 band 6s then sitting on each locality, with a mixed skill set in terms of background, both mental health and medicine. We will have our ongoing mental health liaison nurses very much acting as that now. So they will be the conduit between mental health services, gastroenterology and hepatology services and other services to make sure that they have joined up care. For far too long, we've had very disparate groups and departments where mental health don't talk to medicine and medicine don't talk to A&E, etc. That has to stop, and hopefully this will help us do that. We've got some administrative support and also a support worker to be able to do some of that corgi chasing, as I like to call it. And once we've done our own restructure, which is a challenge in CTM, it'll hopefully sit within my directorate in medicine and GI, because most of these patients end up within a medical setting, and we will hopefully be able to drive that on then to prevent medical complications of alcohol down the line. Achievements, I think we've got buy-in from all the stakeholders. You've got to make sure you've got them all in the room, number one, because there's always some we've missed out, and then you upset someone or new people come along and you've got to re-engage them. But I think we've done a pretty good job as a team in getting everyone around the table. We've had several webinars which has had excellent attendances from across third sector, even service users and private sector individuals. We had a service user event to gain feedback on what a good service looks like. There's no point us thinking that we know what looks good. We have to ask those who've gone through it and what went wrong and what was badly done. And this has led to a song which may make the charts one day, and I think we're going to talk about that in a short while. We've had several national workshops, so part of our job here is not just to create our own service, but inspire other health boards to do the same. And we've engaged with those health boards to discuss what challenges they are facing. I've mentioned dry mester with the aim of preventing harm to mother and baby. We've already started mapping our services to come. We've also engaged with other services, including Cornwall and Birmingham, in terms of learning from how they went through this journey and what they achieved and what they found difficult. The challenges, initially, it was a very quick turnaround. We managed to write the business case in under 7 days rather than 7 months. So I think Dee was probably on the caffeine for those days, as was I and Marie, but we managed to get it done. Engaging the right personnel and making sure you're not missing people out, but also not having too many people in the room was a difficult one, because you don't want too many opinions, because then you'll never get anything done. But I think we've managed to strike a balance there. Our own restructuring has been a real barrier in terms of not knowing who our directorate managers are, where we will sit in the future, a massive turnover of staff and personnel, people changing jobs on a weekly basis. And for those still in the same post, i.e. me and Dee. It's been extremely frustrating at times, and I've managed to keep my cool on teams and not sway once, which I think is an achievement. There's quite a lot of resistance to change and doing something new. We're fine as we are. We're doing a great job. Well, are we? Because my mantra is we can always do better. And a bit like the New Zealand rugby team, if they win by 60, they want to know why they didn't win by 65. And I hope that this project is showing people that, yes, we're doing a good job, but we can do an excellent job. The money and staff and losing money issue, again, with the changes internally in CTM, has been a big challenge, and convincing them that this is permanent funding, but we have to get this established, has been oddly very challenging. And I think post-COVID, the bureaucracy, the normal protocols, sign off, etc., has returned, sadly, and that's been quite annoying to see that we've gone back to NHS snail pace. And I think the final thing is convincing teams that winning the lottery really is possible. I've said this a few times. We've won the lottery here, and we're almost saying we only want to win £10. For once, there is money in a world where no is always the answer to any financial bid. So convincing people this is real, but we have to use it properly now has been a challenge, but one that I think I've enjoyed. So what will value look like, just to finish? Well, we'll hopefully reduce the re-attendances. We won't see our frequent attendance anymore. We'll hopefully achieve abstinence in our cirrhotics, which will reduce admissions because of decompensation, reduce burden on ambulatory services, and increase our referrals for transplant. I know that sounds stupid, but the more people we can get off alcohol, if they need it, they then are valid candidates for a transplant, which is ultimately the best outcome for them. I want to find those hidden populations, not just the obvious ones. I want to find the elder population who are drinking too heavily, the younger children, the pregnant people who are embarrassed. I want to find them and prevent them coming to harm in the future. We're going to plan detoxifications. We don't want people coming to the hospital for a random detox. It never works. And this will allow us to do that. And again, making the user at the heart of our service, not making them come to us. My clinic on a Friday afternoon regularly has DNAs. Why? Because Friday afternoon is not a great time for someone who's addicted to alcohol. They have other things to be doing. So we need to go to them rather than asking them to do all the journey. Data, we have very little data, and I think this is going to allow us to capture that, because we're going to have to justify every step of the way. Increased in engagement with things like back to work services. When people are drinking heavily, they can't work. They then cost us money in terms of benefit. They don't contribute to society. Let's give them their lives back and make them feel valued again. And in the longer term, reducing cancer, heart disease, strokes, etc. And that will only help the NHS, which is already under a huge burden, to save money. For those of you who know my politics, I very rarely quote Margaret Thatcher. I don't think we have much in common, but a quote from her was, "You may have to fight a battle more than once to win it." And I think we've had to fight the same battle many times over with both the same people, but also multiple teams. But I think we are getting there. It's been quite the journey and a marathon, and I don't like running marathons, but it's been something I've been immensely privileged to be part of. And I just want to thank Sally Lewis formally on here for giving us the opportunity. Diolch yn fawr.
Wow. Di, thanks so much. I have to say, yeah, I wasn't expecting to hear a quote from Margaret Thatcher in a Wales Value and Health Centre production, but it's good to have a diverse audience and a diverse backdrop. And if I'd seen corgis running around Merthyr, I would have assumed that there was a member of the royal family visiting, but now I'll know that the alcohol team have got their funding stream sorted and they've mobilised recruits. Thanks so much to Keely and Di.
Yeah.
So we move to the bit of the session where we have some questions and hopefully some answers. And part of that might be questions from Dee and I, and I've certainly got some things I'd like to ask both Keely and Di. But we'll also have some questions from people joining us over Teams as well. So if there are members of the audience or people listening who would like to pose questions to Keely or Di, or bearing in mind Sally Lewis is going to be joining us in a little while as well, then please do pop them in the chat bar and we'll do our best to answer them today. And if we don't, we'll commit to answering them on the website and people can browse those answers later. So Dee, your first impressions, Keely and Di's presentation, did you get any questions jumping out at you following those?
Well, this is our bread and butter, isn't it, guys? So I think I've been on meetings with Keely 3 times this week. But for me, I think with Keely's presentation, it's really great now to have the NHS Executive Wales involved and Keely in post to we've all got our heads down, even in our own health boards, and even though we do get together with others, Keely's piece of work is going to be so valuable. And actually there is a couple of comments in the chats as well saying, is it possible for other people to see what other projects are going on with some contacts? And I know Keely's working on that at the moment. I've had an early sight as part of the Leeds group, and it is phenomenal seeing how in context really such a small amount of money, and it's not insignificant, but when it's shared out, what it's going towards is absolutely fantastic. And I think what we were discussing just before we came on, and Di touched on it as well, when we get an allocation, it comes with a responsibility. So Di was talking about the responsibility to evidence the difference it's going to make and to get that data, but also to be able to share with those other health boards. So even if we're doing a project in Royal Glam and heart failure, can that be scaled across heart failure in our other sites? Is there anything that can be shared in other specialties? And that's just in our health board. And then how do we share that across Wales? So Keely, do you know if others will be able to access that report once you've got it, so that they'll be able to find out what projects are taking place?
Yeah, I definitely think that's something we could discuss for sure. Yeah, maybe coming up with something that we post either on the Value in Health website or my kind of my team's vault, as we like to call it. But yeah, definitely, I think this piece of work is it's instrumental in developing and spreading and scaling across Wales. So it would be a shame not to share it anyway.
Fantastic.
Keely, I loved your presentation. Thank you very much for taking the time to join us today. I have this vision in my head of Dragon's Den with that £5 million pot. Certainly 60 applications for funding is a lot of applications, and a huge amount of work that went into the 44 that weren't successful. And I know of colleagues who put huge amounts of effort into really good applications, but there's only so many applications that can be accepted and so much money to go around. So have you thought of any of the benefits or any of the feedback for the unsuccessful applicants? It may be difficult to deliver feedback to 60 applicants, but I was just wondering, is there a mechanism for that?
I think maybe a year or so ago, when the kind of feedback went out, I'm not sure of the extent of, and Sally may be able to kind of help this, because I know she was directly involved with what went back to the health boards and trusts. But I guess what I would say in terms of just a bit of advice, just liaise with your kind of value teams and your finance teams, and liaise with whoever you can to try and discuss how you could potentially take this forward, whether it be an internal business case. I think I think some health boards did actually do it in that way of some of the bids that weren't successful. So yeah, that would kind of be my advice, is just try and speak to people.
I have to say, anecdotally, and Sally might have something to say on this as well in a second. Anecdotally, what I have seen are teams who, even within their own health boards, may have struggled to get profile or awareness of the thing they're trying to do, but because actually they put a really good bid into the allocation fund, which wasn't successful, nonetheless it did create awareness of the thing they were doing, which was never there before. And then subsequently they've gone on and actually had a lot of help to get the thing off the ground. So Sally, did you want to comment on any of that? Have you had sort of interactions with teams around the country who weren't successful?
Yes, absolutely, Dave, and thanks for the session. It's absolutely amazing. Thanks, Keely and Di. It was really difficult. There were 64 bids, I think, and almost every single one of those was really great. So we had to be really quite strict on how people were going to assess the success of how they were going to spend that money. So as Keely has said, we really recommend, liaising with your local value and health teams, because they will help you to do that and frame it in the right way. We also thought about likelihood of success. We thought about trying to direct the money to places where perhaps there hadn't been a spotlight before, to create a bit of equity. So the alcohol care project is a really good example of that. So we did really try, and the other thing I would say is, just because you weren't successful didn't mean it wasn't the right thing to do, and didn't mean it was a bad project in any way, shape, or form. And we would have liked to have funded them all. So, as I don't quote Margaret Thatcher either very often, but I think that's quite a good quote. In that, you know, don't give up because you were unsuccessful. Find out why you're unsuccessful. Reframe the bid. Try again in the next round, or as has already been suggested, find another route through your own organisation and keep nagging until you get it over the line.
And I can certainly say in CTM, we actually, although it was a very quick turnaround, we actually put in place a triage across our organisation so that the bids that went forward to the national team were wholly supported by CTM. We were very fortunate in having our alcohol, and we were part of the AF and hypertension bid. But then those that didn't go forward, we did keep some of our allocation back, and we were able to support some of those going forward as well. And some of them didn't actually need funding sometimes. So that triage process just helps to bring people together, and actually you just need some help and advice. So it's been a really useful process, and there's lots of learning from it as well.
And Dee, I had a question for Di relating to the project and the application. So Di, what are the measurable outcomes that you're being held to account for in terms of your value project? What are the things what's the pitch?
Yes, I think it'll be certainly attendances at A&E. I think readmissions. We're also hoping to do some quite novel things with the police force, for instance, and the justice system. So even looking at frequent arrests or antisocial behaviour in those frequent attenders in the community. So those are the type of initial markers in the sand. And I think longer term, we'll be looking certainly in our clinic as to those who are still drinking with cirrhosis and decompensated liver disease. Do they reduce or stop? And then do they compensate? Do they have less stays in hospital? And that will probably take more of a year or two to measure, but for the first time we've had to focus on those held to account outcomes, and I think we're very bad in Wales at collecting accurate data very often. For the first time we are now data focused and data driven for the first time, and I think just picking up on what Sally said, I think I feel immensely privileged to have this money for an unsexy specialty, because liver disease is very often seen as that it's brought on yourself, and it's very interesting since we've had this funding, it's stimulated a lot of interest within the health about liver disease. AMs and MPs are writing in about liver disease, and it's helped me fight a few battles when I was almost prevented from screening for hepatitis in Park Prison, for instance. Financially, it might cost a bit of money, but I said, well, are you saying that prisoners aren't as worth treating as someone with bowel cancer or breast cancer? Suddenly the money was found, because I emphasise that these are people that if you invest in now, you'll save a lot of money down the line. So those are some of the things that we're hopefully going to measure. And I think some of it we'll be learning as we go. And that's why we wanted to touch base with people like the Cornwall team, the Liverpool team, the Birmingham team, to understand what they measured as success and what they measure now routinely. And that's where we've come up with some of these metrics.
Yeah.
And I think it's really easy to, you know, in value terms, often reduction is the big word that everyone wants. Everyone wants reduction in A&E, reduction in admissions. But as we found, actually, we want to go out and find people. We want to go and find people that are not coming through. We know that we don't have any referrals coming through from midwives, yet we know that parents are drinking through their maternity, 9 months. So we know that actually figures might go up, but that we will be providing value and supporting those people. And hopefully, as you say, you'll be out of a job further down the line. But I really wanted to pick up. So unfortunately, we were going to play a song for you today, but we couldn't get the sound quite right. So we're going to load it up. But one of the things we have been able to do, Di, is really concentrate on person-centred, value-based healthcare approach. And actually, I'll drop this in now. Next month, July the 28th, we have a whole session on person-centred, value-based healthcare with Tom Kelly, and Navjot Kaur is going to join us again. But what we've been able to do with this, Di, as we develop a new service, is really get the patients, as you said, asking really unjudgmentally, what did go badly? What didn't work? And they were very brutally honest with us, weren't they? Because they felt unheard, unvalued and unseen. And they're not the people that are going to come on and do a cameo shot or come and join a big meeting. So we did actually, in one of our sessions, record a song that captures how they feel in the sessions. And they picked up things like, a lot of the time, alcohol clinics are in the furthest parts of the back of beyond, but of course, many of them don't drive because of their alcohol addiction, and therefore 3 buses and running for buses means they often miss it. So let alone on Fridays, we somehow make it very difficult for people to get help. So, but what were your views? Because obviously you came over and spoke to the service users to be able to get on the ground in that way.
Yeah, it was a very humbling experience, I think. It probably reinforced what I knew in some ways, that far too often my colleagues do judge these people, and we do exclude them and marginalise them even more at the time of their life when they need that the least. Yeah, I think it was great to hear sort of some of the comments that they've overheard, or I had to go to the back, like you say, of Beyond, or in some random dingy building. And I always joke, we need to have a fun bus, essentially. You need to put me on a bus and I need to go and find them in the community. And you could have your social worker and your free hot chocolate and sandwich if you come for your appointment. But I think, it reinforced it. Again, I think as well that you can't judge people. You look at the people in that room that day, you wouldn't pick any of them out as probably having an alcohol problem. And I think that's the big thing we need to change. And this song will hopefully do that, is not everyone's on a park bench in dirty clothes out of it at 6 o'clock in the morning. Most of those were functioning people who still had jobs or had lost their jobs because of everything. So I think those are the big things I picked up from that, is never judge a book by its cover, and actually give these people the opportunity, because look how many of those have changed their life around.
Thanks, Di. Di, something you mentioned in your talk was about putting yourself out of a job. And as someone who works in an emergency department, I often think upstream, public health, those interventions, particularly around children and injuries and so on. I'm just wondering, and Sally might have a view on this, but if you go far enough upstream from your service, eventually you get to the fact that alcohol is cheap and widely available across communities in Wales and the UK. And it goes back to social determinants of health and so on. I'm just wondering, Sally or Di, at what point does the world of value-based healthcare collide with policy and legislation? Because ultimately this £15 million is coming from Welsh Assembly government, who are the legislators, aren't they, for the country we live in? So is this a conversation that will then extend beyond value, Sally? Sorry.
Well, there will be. So I'm speaking for myself here, not for any, not for the government, but obviously there are a range of political views on this. I think that we have such a tsunami of healthcare problems coming at us because of environments that encourage alcohol use, the obesogenic environment, that I don't think there is personally any longer any option but for the state to step in and start to help us create a healthy environment for the community. That's my personal view, because it's alcohol, it's type 2 diabetes, it's a whole range of healthcare problems, and we need to do something in society to tackle that. Yes, that is my view, certainly.
Thanks, I would you on the spot with a broad existential question. Sorry, Di.
Could I just pick up here? I think that they don't have to be antagonistic. I think they're complementary in some ways. I think our work is supporting those within that problem. And I think things like minimum alcohol pricing, for instance, like the Welsh government and Scottish government have taken responsible steps to try and change people's behaviours. It perhaps hasn't worked yet. And I think that's why one size doesn't fit all. I think changing the availability of alcohol, helping those with problems, but changing the next generation's opinion of alcohol, I think is key. And we've seen with smoking, haven't we? Smoking's not a great thing now, but vaping is for young children, because we haven't educated them about the harms. And I think the same with alcohol. Let's get into the schools, let's get into those communities and understand why people turn to Scrumpy Jack on the street corner, for instance. Why are they doing that? Because they haven't got anything else to do. And coming from Merthyr, I often see that it's the only thing that is there for people. So I think it's definitely something for government to have to focus on and complement rather than antagonise the work that we are going to do.
Oh, thanks, Di. So we've got some questions in the chat bar from who people are listening to the session, and Adele Cahill, apologies Cahill, we're in Dublin where I come from, we might say Cahill or we might say Cahill, but Adele said, we can see this allocation makes a real difference. What are your thoughts on how we sustain this work without the funding, and try to break some of the barriers around this? And I wondered, is sometimes the reluctance to grab funding opportunities like this is in some way reflecting a fear that you'll then have to fund it in the longer term. So essentially, how can we continue this work or initiate this work in the absence of an allocation fund? And I don't know, Di, if you've had thoughts about this, what the future looks like.
We had this right from the off. My previous directorate manager was very unwilling to take responsibility because, oh, well, what if the money runs out? I think this will hopefully help us through a very difficult time in the NHS financial history. And hopefully in better times, it'll be easier to get money. But I think these type of things will hopefully show the NHS how we should be spending money. I think you can name umpteen things that we waste millions of pounds on every year, whereas these projects have to show their value, and this will hopefully change the culture within other parts of the NHS to actually really focus on stuff that matters rather than stuff we've always done the same. So that's my personal feeling on it. And yeah, it's going to be tough without money, but I think it's another way of us showing as clinical teams that if you want a quality service, you have to invest, and the bottom line isn't always the right answer.
And I suppose also it comes down to outcomes. So if you can measure outcomes and deliver on those outcomes, then it makes the case, doesn't it? And you've had that sort of seed capital in the first place. So Dee, there was a question from Alex Hicks, I think.
Yeah, for Keely. So Pananda Keely, I'm going to read this out. So I am new to the Value-Based Allocation Fund. So thank you for the interesting overview. I was interested in whether any of the bids had taken a life course approach as opposed to clinical specialties. I'm especially interested in children's health, so wondered if any of the successful bids had focused on children and young people.
I'm just going to pop back to the last question first, if that's okay, Dee. So in terms of sustainability without funding, I think absolutely this is where effective utilisation of resources comes in. I think we need to just be making sure that we're spending our 10 billion in Wales on the right things, and that's absolutely where value comes in, you know, funding or not. Ultimately as well, you know, I think as new technologies come on the market and new kind of new ways of care come on the market, we need to be disinvesting in the things that, you know, aren't quite appropriate anymore. So I think we need to be taking quite a holistic view and just always checking in to see where we are, you know, where our funds are being spent, and other perhaps areas that we need to take a step back now and draw back, which I know is always, you know, really difficult. So that would be my view on that one. In terms of the children's and young people part of the allocation, so I think Sally did come back with a message in the chat about this. So as far as I know, and there was quite a lot of projects that I have to think through in my brain, I don't think we did any with children and young people. I would say that, you know, in my previous roles in mental health and family therapies, there are kind of streams like the RPB and transformation funding that kind of is directed to children sometimes, you know, especially in like the CAMS area as well, with the mental health investment that we get from mental health. So I'm not sure, Sally, if you want to come in, you know, any more on that one, or.
Yeah, so thanks, Keely. So from memory, I don't think there was anything in the actual allocation fund in this round, and I think that probably represented people tackling high volume problems within health boards, really. It certainly wasn't any kind of prejudice against one clinical service or one group of patients against another, far from it. But what I can say is that there's plenty of thinking around that life course approach and a value-based healthcare approach to children's services. Dave and I have had a lot of conversations about this. Nick Wilkinson, our co-chair, usually is doing some work with us on this, and somebody's already mentioned the regional partnership boards and child and adolescent mental health are people we're all having conversations with. So not the allocation fund, but definitely part of the thinking.
Yeah, and I would just add for that from as one head of value-based healthcare, but I know my colleagues are doing the same. Just because projects don't get allocation doesn't mean they're not getting our support. So there are a number of paediatric specialties across CTM and across Wales that are having value-based healthcare input, so developing proms and prems for children and young people, so whether it's children and people with diabetes, or as we've mentioned, the fecal alcohol syndrome. And what we're able to do as well, because we get that oversight of the allocation, we're able to create connections through those programs as well. So we bring all of those clinicians together and start realizing that we can improve the referrals and the knowledge between all of those projects and those specialty areas as well. But definitely one to look out for. So I know back at my ranch, Emily Payne is on at me already to, okay, what are we going to do around the peds? And I'm sure it's the same in the other health board areas. So thank you for your question, Alex. So our time it goes so quickly when we're here. So Sally, if I can bring you in for a bit of your roundup, if that's okay, and hand over to you.
Thanks, Dee. And as you know, I don't normally kind of wade in at the end and hijack a session, but I am taking liberties and doing it this time because I feel so strongly about this topic. One of the challenges that I've had about this allocation fund on quite a regular basis actually is, well, you know, why do this? You know, it's a tiny amount of money in the scheme of the overall health board budget. What's the point? People should be just doing this as part of core funding. And then on the one hand, that's a fair challenge. But what I would say is that whilst value-based healthcare and small funds like this are clearly not going to plug the hole in the deficit, as Keely said earlier, and they're not a panacea, they absolutely drive behavioural change. Even talking about the bids, as we've already heard, drives behavioural change and starts to create a shift in focus around what we always measure to other important things as well. So it really does help with equity. It helps us fund things which have historically not been funded at all or been seriously underfunded for various reasons. And Keely and I are trying to now, well, we are doing a piece of work to categorise how those funds have been spent, because actually when you look down, it looks like a long miscellaneous list, but you can put those investments into categories of secondary prevention, supported self-management, data infrastructure, capacity releasing schemes. And I think then health boards can start to see how how they can fund these types of approaches to build for longer term sustainability. And that's certainly something we would like to feed back to the Minister and Welsh Government as well. But really, the main point for me about this, other than the behavioural change, is the equity piece, you know, because we have a strong focus on certain conditions and certain clinical areas, which I'm not going to name, but if we neglect alcohol problems, if we don't get really underneath the type 2 diabetes problem, and frailty and dementia and all of these really big problems for us in society, we will be consuming more and more and spending more and more on healthcare whilst not improving people's outcomes. So whilst this isn't going to save cash in the short term, it's certainly going to avoid costs in the medium to longer term, and give us the courage and confidence to transform the way we deliver healthcare so that we're truly beginning to meet the needs of our population in Wales, and begin to reverse the inverse care law, which was described by that wonderful Welsh GP, Julian Tudor-Hart, was published the day before I was born. So it would be quite nice for me to retire thinking we've made a tiny, tiny amount of progress against equitable healthcare in Wales. So thank you for letting me hijack the session, because frankly, it's a shameless plug that hopefully somebody will listen to this and give us some more money.
Thanks, Sally. It was the friendliest hijack that I've ever seen. Thank you so much for joining, and thanks for fielding some of the questions as well. So it's going to be shortly time to wrap up the session from Dee and I. So first of all, thank you to Keely, to Di and Sally for joining us today. I found it fascinating to hear about the allocation from the inside, from Keeley, and just how it all hangs together. And I still have an image of Dragon's Den. I know a few of the dragons, but some I don't know. So thank you. And Di, we got All Blacks in there, we got Corgis, we got Margaret Thatcher, but most importantly, a fascinating insight into the value work you're doing in Cumtaff, Brum Organic. And thanks so much for sharing that. And particularly because Nick and I have always felt with the Healthcast and Dee as well, that we want to know not just about the gloss, not the success, but also the hard-won battles. And you mentioned about it being a marathon, a bit of a marathon, and you're not liking marathons. I'm not built for a marathon. I'm not built for a sprint either, so I'm not quite sure what I'm built for. But I totally get the time spent in the trenches. And so thank you so much for sharing that. Dee, anything that jumped out at you from that session?
I think really the key part is that we're very, very lucky to have some allocation, but as I said, with that finance comes responsibility. That is a different way of giving money in the NHS. Normally, you know, there's a business case, you get your funding, and then you might have to do an evaluation at the end. For me, the value-based healthcare approach is really supported. We're really targeting where the money is going to, and I think you can see, you know, by the fact that Keeley's in the NHS executive, keeping an overview of where it's going, being able to share that, you know, the clinicians coming to me saying, yeah, do you know what, it's a hard slog, but it's worth it. And actually, we'll be able to know more about what the outcomes are and find more patients. And then what Sally was really saying then about, okay, if this enables us to give the golden tick around what high value care is, then actually put some more through our pathways and let's start demonstrating that on the whole of our bank sheet. Let's really know what value we're getting for the full allocation that we get in the NHS. And that's actually been echoed in a lot of research that's come out through COVID, that value-based healthcare can really help the systematic change in the way that we allocate and fund money. So I've really enjoyed today. I'm going to give a hijack plug as well, because it is Alcohol Awareness Week next week, 3rd to the 7th of July. Across CTM, we are doing a number of things with our third sector and with our service users, and we're happy to put that on our web pages. But link in with all of your local areas too, because there'll be different things happening in your local area. And let's give these service users and the clinicians that support them really the support that they need to help and continue helping our patients. So just a huge thank you, really. Very quickly, so I mentioned that we are going to be moving into July the 28th on our person-centered care podcast. So Tom Kelly and Navjot Kaur will be joining us. Di's project is actually a person-centered value-based healthcare project for CTM. So you've had a good lead in this week, but next month you'll get to hear all about that person-centered approach and what it really means and what we're doing in Wales. And that's part of a global project. And then during September to November, there's going to be a 3-part series called Value in Planned Care, which will be including the outpatients model, PROM, self-management pathway. And there's going to be a range of guest speakers on that one, including Sally Lewis and William Oliver, all across to look at the micro, meso and macro views, including some service users. So we've got some exciting times coming up. If you haven't got the answers to your questions, try to get in as many as we can. Di, Keeley and Sally, if you wouldn't mind having a quick look through and popping in some answers for us, just so people have got those. And again, if you feel like rewatching us or telling your colleagues to come and have a listen, it was a good one, then don't forget to go on the Welsh Value in Health website where the recording will be available. So thank everybody for your time. Thanks for having me back again. I'm back at the next one, and I still won't be Nick. He's having a good break here. So really just thanks everybody for your time and another stimulating podcast session.
Fantastic. Thanks everybody. Thanks Dee.
Thanks guys.
Cheers.
See you next time.